So, a couple of common problems now, things that we see quite a lot in the antenatal clinic or get asked a lot about by our patients. Morning sickness. This is a really important condition because it's really common. About 80% of pregnant women will experience nausea and vomiting at some point in pregnancy. Interestingly, only 17% of women actually get nausea and vomiting exclusively in the morning. Morning sickness can last all day, or it can actually be worse in the evening. It's commonest in the first 12 weeks, and it does tend to abate by about 12 to 14 weeks of pregnancy. But for some women, it can actually be quite prolonged and can last for the whole pregnancy. In general, mild nausea and vomiting is self-limiting, and it's not harmful to mum or baby and isn't anything to get too worried about, unpleasant as it is. However, there is a more important condition called hyperemesis gravidarum, or simply put, hyperemesis. This is very severe and intractable nausea and vomiting in pregnancy. It affects about 0.3 to about 2% of pregnancies, and there is some geographical variation in that around the world. Some populations are much more susceptible to severe nausea and nausea and vomiting than others. In Ireland, about 1% of pregnant women require hospital admission for hyperemesis. And there are various definitions of hyperemesis in use. Even as doctors, we can't really agree what's hyperemesis that makes it distinct apart from just severe nausea and vomiting. But the sort of general definition is that it's intractable vomiting, where you're vomiting at least 3 times a day, become clinically dehydrated, and you have weight loss. And weight loss tends to be defined as about 10% weight loss. So for a 50-kilo woman, that would be a 5-kilo loss, which is quite significant. The reason why we as doctors worry about hyperemesis is because if it's severe, prolonged, and left untreated, it can cause significant issues for mum and baby. And women with hyperemesis may require inpatient treatment, IV rehydration, and vitamin supplementation. So if you have really bad morning sickness, what should you do? Well, avoid personal triggers. There were some things when I was pregnant that used to make me sick, just even thinking about them, and everyone will know what those triggers are. So it's always a good idea to try and avoid them. Drink as much fluid as possible. Fluid is important, food is less important. As long as women are drinking, they can tend to stay out of hospital and avoid inpatient treatment. Obviously, speak early to your midwife, your GP, or your consultant to get advice. There are drugs available, and we've recently, to help with nausea and vomiting pregnancy and in hyperemesis in particular, and we now have a very good national guideline that was developed here by the Institute. The first-line drug is a drug called Carabin. Now, there's a lot of controversy about Carabin at the moment because it's actually can be quite difficult to obtain, and it's also very expensive. But it is a very effective drug. The dose is 1 capsule in the morning, 1 in the afternoon, and 2 at bedtime. As a first-line treatment, it's very effective, and over 80% of women find that within 24-48 hours of starting Carabin, they actually have quite significant relief. But if it's not enough or ineffective, then there are other drugs, such as Stemetil and Zofran. These drugs have been prescribed for nausea and vomiting pregnancy for many, many years now, and we no longer keep data on women who've been exposed to these drugs in pregnancies because all the data shows that they're safe. We often get asked about the safety of drugs in pregnancy, and particularly for morning sickness, because of the long legacy of thalidomide. But we do have a lot of experience with these drugs, and they are safe. And it's much better to be taking medication than to become clinically dehydrated and nutrient deplete, because that, as I said, can lead to quite significant problems for mum and baby.